on the fetus and on the mother. And lastly, what are the advices that the healthcare workers can do it in dealing with the confirmed or suspected COVID-19 cases. So just one thing to keep it in our mind, that this disease, every day there is a new guideline, there is a new update. So maybe tomorrow, after tomorrow, there will be a new guidelines or new information. So our presentation, the information is until today. So first of all, introduction about the disease. So coronavirus is a new strain of, or COVID-19 is a new strain of coronavirus, first identified in Wuhan city in China. Other coronavirus infection include MERS, which is Middle East Respiratory Syndrome, and SARS, which is Severe Acute Respiratory Syndrome. The virus appears to have originated in China towards the end of 2019, hence the name COVID-19. 2019. Currently, the country with the highest number of infected individuals is the United States, and among Europe is Italy. So what is the clinical picture? What is the symptoms of the patient with the coronavirus? Basically, it's like a flu-like symptoms, high-grade fever, cough, shortness of breath. And just to keep in our mind that the patient, a patient with a confirmed COVID-19, they may present asymptomatically. The incubational period is from 2 to 14 days. This classification of the severity of the disease based on the Saudi Society of Maternal Medicine, we can categorize these into 4 categories, and based on the category, we can manage the patient. So we have mild, moderate, severe, and critical. So the mild form, asymptomatic or mild symptom, and the patient is vitally stable with no comorbidities. The moderate, mild symptoms, the one that we mentioned previously, fever, cough, shortness of breath, with stable vitals, but they have comorbidities, diabetes, hypertension, and so on. The severe, the patient symptomatic with vital instability. So they have heart rate more than or equal 30 breaths per minute, and the oxygen saturation is less than 94. The critical classification, the patient is presenting with an organ failure or respiratory failure requiring mechanical ventilation or ECMO. The other thing is there are certain persons appears to be at increased risk for developing the infection. And this is very important because maybe some people will say, it's fine if someone is young, healthy, got the infection, maybe he will heal from it, maybe he will not have this severe form of infection. But the problem is if he infected other persons, like the one with like the old age, older than 60 years, or the one that have a medical illness, or the persons who are immunosuppressed. Okay, so now who are the individuals that we can call them a suspected COVID-19 case? So we have 2 scenarios. The first one, patient with acute respiratory illness, presenting in the form of fever or recent history of fever, cough or shortness of breath, the symptoms that we mentioned earlier. And in the 14 days prior to these symptoms, they have one of the following. If he traveled to a high identified risk area, or if he was in a close contact with the confirmed COVID-19 case, or if he's working or attended a healthcare facility where patients with a confirmed COVID-19 were admitted. So this is the first scenario. Any of the symptoms, and prior to these symptoms, one of the following, if he traveled coming with a severe acute respiratory illness will require an ICU admission and in the form of acute respiratory distress syndrome. And all of the following conditions have been fulfilled, which are testing for influenza and MERS coronavirus are negative, clinical assessment indicating that the patient is not improving and has no clear underlying cause, with or without an identified epidemiological link to a confirmed COVID-19 case. So basically, the patient will come in a very severe clinical picture. Okay, this is a checklist in triaging the patient when first they come. Usually they do it in the hospital by the nurses. So it's like a checklist. And if the patient had a score of 4 or more, the patient should be placed in an isolation room, and we should also inform the medical director. So basically the things that we mentioned, fever, the symptoms, fever, cough, shortness of breath, sore throat, and a risk of exposure to COVID-19 or MERS. And then we're going to put the total score. And if it is more than 4 or 4, the patient should be in an isolation room. So now we know how to diagnose the patient or how to label the patient confirmed COVID-19 or suspected case of COVID-19. So now how can we clear this patient? So in order to clear a patient, either for a suspected case or for a confirmed case, we're going to start by the suspected case. So the patient should test negative for the PCR regarding coronavirus, and there is a clinical improvement and no other reason for isolation. So this is for a suspected case, when to do a discontinuation for the isolation. If the culture is negative, there is a clinical improvement and no other reason for isolation. What about for the confirmed case? For the confirmed case, the patient should be completely asymptomatic from the symptoms that we mentioned earlier and should have 2 consecutive negative cultures. Okay, so now we're going to talk about the transmission. So person-to-person transmission is mainly through respiratory droplet. So when the infected individual cough, sneeze, or talk, the other person will get the infection via the respiratory droplets. This is one thing. The other thing, the infected person also may cough, sneeze on surfaces, and then the other person comes in contact with these surfaces and touches his eye, nose, or mouth and infect him or herself. Until now, the coronavirus is not considered as a sexually transmitted disease. Maybe after 1 day, 2 days, or after a month, they will put a new guidelines or they will put a new information, but until now, it is not considered as sexually transmitted infection. This picture will show us how long the virus will stay, for example, in the air up to 3 hours, on a copper surfaces up to 4 hours, on a cardboard up to 24 hours, on a plastic 2 to 3 days, and on a stainless steel 2 to 3 days. So that's why it is important to apply the hygiene settings on these surfaces. Important points regarding the spread in pregnancy, which is more important to us as an obstetrician. Like heart disease, lung disease, or diabetes. Until now, there is no evidence of transmission via genital fluid. What about the vertical transmission? So, 2 cases of a possible vertical transmission have been reported, and they took swabs from the amniotic fluid, cord blood, neonatal throat swab, and breast milk, and all samples tested negative, as well as they took 3 placenta from an infected mothers, and they swab them and all test negative for the virus. So until now, there is no evidence of vertical transmission. What is the effect on the fetus? Currently, there is no data suggesting an increased risk of miscarriage or early pregnancy loss. And there is no evidence of intrauterine fetal infection, so unlikely there will be a congenital effect. What about the effect on the mother? The majority of a pregnant woman will have a mild to moderate flu-like symptoms, like the one that we mentioned before. And also, the patient may present with no symptoms. Until now, there is no maternal death from COVID-19 have been recorded. Are there any delivery consideration? At the end of the presentation, we will talk in details about it, but just briefly, coronavirus infection itself, it is not an indication for delivery. Okay. So now we're going to talk about just for doctors or obstetrician regarding how to deal with patients confirmed or suspected cases of coronavirus. I'm going to talk about the antenatal care. It's just a few points. For a suspected or for a confirmed cases, the patient should be in an isolation room. Expected.
Mahmoud?
Yes?
Can you go back one slide? Antenatal care. Yes. So, antepartum care slide. Just before you go further, I would like to ask, for our experts who are with us, the task force committee members or other colleagues, MFMs, if there is anything to add, if you'd like to add anything or comment on anything mentioned so far.
Yes, sir, I have a question to Dr. Mahmoud. You said to clear patients who are infected or confirmed, to clear you need the 2 negative swabs.
Yes.
You did not mention how far apart, if we do it now or after 2 days. So how far apart we do the test to say that she's clear?
They did in the guideline, they did not specify how long, but they just mentioned 2 consecutive PCR results are negative.
I think they have to, because you can do it now and it is negative, and you can do it after 5 minutes and it is the same. So they have to put the line like 24 hours, 48 hours, whatever. But anyway, if it's not there in the guidelines, في أحد عنده comments أحد كان.
I think it should be 24 hours apart.
I don't know, but I'm just asking. It is important point to look into.
Definitely.
The second thing is the transmission. We know till now there is no evidence of maternal fetal transmission.
Yes.
However, 1 or 2 case reports showed, or at least one case report that I am aware of that was published 4 days ago or 5 days ago, that they tested the neonates, and they found that there is an IgM, an increase in the IgM of the neonate for the COVID-19. An IgM does not cross from the mother to the baby because it is a large molecular weight, so it does not cross. So most likely this IgM is coming from the neonate. So the neonate did produce this IgM. I'm repeating, it's only one case. And 2 days ago also there was a series of, I cannot recall how many cases, but they did the same test and it was negative. The IgM and the IgG was negative for the neonate. So there was something wrong on that case, or it was the right case, and in the future we'll have more information about the vertical transmission. Therefore, in our guidelines, we put a statement that we have to be careful in dealing with the neonate for those mothers. We don't have to consider it as 100% sure that there is no vertical transmission. Till now, there is no evidence, but we have to be careful so that if a new evidence emerged, we are on the safe side for now. Shukran, ya Mahmoud. Wallah, I enjoyed your presentation. It was an excellent. It was an excellent. Shukran.
He's not finished yet. We just took a pause to get the any comments from our experts. Any other comments?
If you just allow me, Yasser.
Yes. Who is this?
Eman. It's just whomever. Okay.
Wait 1 second. Let me. Yes, Dr. Eman. And if you can unmute and talk.
Thanks. You've done amazing presentation, mashallah, barakallah alaik. Your information are concise and clear and to the point. One thing that you've made, actually, I don't know, you didn't talk about it, maybe you've read about it, but you didn't think it's important enough to talk about it, or maybe I missed it. In method of transmission, you've talked about droplet, you've talked about on services, but there have been an emerging evidence of fecal oral transmission has been reported in the literature as well. Have you found anything about that or looked at it?
Question to Mahmoud.
Mahmoud, have you heard did you hear the question?
I don't think he's with us anymore.
Oh.
Or did we lose him?
Yasser.
Yes.
Hi, it's Khalid here. How are you?
Hello, sahlan, bro.
Just, to add to what Dr. Bondagji has said, this morning, I was hearing the news.
One second, bro. I mean, Dr. Eman is not finished her point. We just wait for her to finish. But Dr. Mahmoud, is he still around? Dr. Mahmoud?
Hello, can anyone hear me?
Yes.
Yes. Did you hear the question of Dr. Eman?
Yeah, yes, about the fecal-oral transmission.
Yes, please answer if you have an answer.
I just, they just mentioned the fecal-oral transmission, but they didn't give any information or more detail about it. That's from what I read. Maybe كان في new guideline أو في other guidelines. يعني they gave more information.
We bring this up because it's as an obstetrician for us, and during time of delivery, it's important for us to know what's the viral load exactly in that, and what's the risk of transmission exactly when it comes to fecal transmission. Because it has been found some of the symptoms they have GI symptoms and they have diarrhea. And we want to know what's the risk for us, because usually a lot of times at time of deliveries, we face patients who do have bowel movement at time of delivery. We are all wearing PPE and we have to take it very seriously, especially when we talk about asymptomatic patients as well. So this is what I wanted to bring it up, and I see what's your think and what's the other experts thinks about it. And that's it, I'm done my comment.
Okay.
Thank you, Dr. Eman. Prof. Khalid, you have something to mention.
Yeah, I just added to Dr. Bondagji's. This morning, there were 2 cases, neonatal cases at St. Mary's Hospital in London, and both neonates tested positive 2 days ago. And today, the chief pediatrician there came and refuted that and mentioned, there is no evidence for the vertical transmission. But as he said correctly, that, we need more work. But at the moment, vertical transmission cannot be excluded, and we cannot confirm it as well. But I think it depends on the availability of the kits for testing all the neonates, and whether we'll be able to do this, for example, even here in UK, it's going to be very costly. And they are considering doing it on certain cases for those women who have the antibodies, not for those who tested positive. And that's going to create a lot of dilemma as well for all the world, for the neonates.
Well, thank you, Prof. Khalid. So I think we'll...
Hello?
Yes, who is this?
Yeah, Dr. Shadi, RTP and Faqih. Just I want to share you something about vertical transmission. Theoretically, vertical transmission can happen. You know that SARS-2, Corona SARS-2 viruses enter the cells through via AC receptors. So we know that AC receptors are found in placenta. So theoretically, it can be transmitted vertically, but till now, no evidence. I think because our data, we are now, there are many ongoing, this ongoing pandemic, and many data is till now not published. So theoretically, for our residents, it can be transmitted. So till now, no evidence. The virus not isolated in amniotic fluid or in but theoretically it can be, because this virus enters the cells through the ACE receptors, and these receptors are already expressed and can be found in the placenta. Regarding when we consider this negative and when to repeat the test, the data, what I read, in the early disease, the viral load may be very low, so can be negative, the PCR testing. And after 3 to 5 days, more viral replications, so it can be positive. So they repeat it usually if we have a highly suspected case with fever or asymptomatic contact with other confirmed COVID. They repeat the test 3 to 5 days from the first negative. This is the data what I found in non-pregnant ladies. Thank you, Dr. Yasser.
Thank you, Dr. Shadi. So we'll continue the hand with the presentation by Dr. Mahmoud.
Okay.
Please continue.
Can everyone hear me?
Yes.
Right. So we're gonna talk about, we're gonna give some advices for services caring for women with a suspected or confirmed COVID-19. I'm only gonna mention the antepartum part, and then Dr. Sahar will continue. So for any patient suspected or confirmed case,
sorry to interrupt you here now, but I just want to emphasize that this part of the presentation is very, very important for all of you to hear. The majority with us today are our frontline physicians, our residents, and they're going to be the first people who are going to be coming in contact with our patients. We want them to be safe. We want them, to make sure that they take all the necessary precautions when they are going to be seeing these patients with suspected or confirmed COVID-19. It's very important that, in your hospitals, you have like obstetric drills, or simulation sessions on when you have patients who are going to be presenting with suspected or confirmed COVID-19. I did a quick drill a few days ago. Maybe some of the residents are with us now here in our hospital, where we had the drill of a patient coming in labor, on her way to labor and delivery, in labor, and she is COVID-19 positive. So again, this drill showed us a lot of things, a lot of areas for improvement with regards to how we think who's going to be taking after this patient. So having these drills is very important. Being prepared, what to wear and how to wear, the donning, and then the doffing is also very important. This is what Mahmoud is going to be presenting now. So please focus well on this next, in the next few slides. Fadwah, Mahmoud.
So a patient should be in an isolation room. And as we mentioned before, the checklist will help us to triage the patient. Expectant management at home may be appropriate for many women. I mean, for a low-risk antenatal follow-up, I'm gonna show a slide that tell us how frequent the patient they have to come to the clinic in person, and the other visits we may do it through the telephone. Healthcare providers should consider delaying routine antepartum care appointment, and I will, as I said, I will show the table for that. Maternal medicine. It tells us how many times that the patient needs to come in person to the clinic in a low risk pregnancy. So if a patient has like a patient without any problems, without any high risk things, they should follow this table. So first of all, from 11 to 14 weeks, the patient will come in person for the booking visit, for the antenatal routine blood work, and for the dating scan. And then from 20 to 24, the patient also have to come in person to do the anatomy scan. And at 24 weeks, the patient can do the oral GTT. And then here, if the patient is a low risk, we can contact the patient through the telephone to, if the patient has a normal, GTT, we just can inform the patient. And at 32 weeks also, the visit, we can do it through the telephone. And at 36 to 37 weeks, the patient has to come for the GBS swab, biophysical profile and growth scan only if high risk, and also the plan, the mode of delivery. At 38 to 39 weeks, through the telephone, person visits with the biophysical profile, and at 40 to 41 weeks, plan the delivery if not delivered, and do the biophysical profile. And the postpartum visit, we need to do it through the telephone. This table is from the Saudi Society for Fetal Maternal Medicine, and it explains the low-risk pregnancy follow-up. Regarding the PPE, the personal protective equipment, anyone talking?
Mahmoud, yes. Can
Yes.
you go back to that table, the table again? So I'd like to invite or ask Dr. Eman. Dr. Eman Alsulmi, she did the most work on this table here. So Dr. Eman, do you have anything to add with regards to this table here with regards to suggested follow-ups?
It's actually, he explained it really well. The idea here is to, because we know in a COVID-19 pandemic, the number one, we're talking in this table, just to clarify things, we're not talking about suspected or confirmed cases. We're talking about antenatal care in a pandemic era. So we want patients to stay at home as much as possible, minimize in-person, minimize getting out of the house for pregnant patients as much as possible. So therefore, we made the in-person visit minimized. We based it actually on a study done in 2011 by Nicolaides' team group, and they talked about the inverted care or prenatal care, where they minimized the antenatal visits from 15 or 16 visits during the pregnancy to 5 visits in person during pregnancy, and they didn't even use the telehealth in between as well. Here we thought, and that's at that time, it was just proposed for low risk patient, there was no pandemic. So we thought that this time it's actually very appropriate to take that study and make it applicable to our current situation and add to it the telehealth as it's actually becoming more useful in our current situation in the past few months, especially in Saudi Arabia as well. Patients who wants to have a refill prescription can have it done. A lot of hospitals now, like the National Guard Hospital, they have patient can reorder their medication through the application. Other hospital patients can just call their physician, ask for the refill. The pharmacy hospital can do the refill and send it to them through the mail. Patient does not have to get out of the house. All these things that we have to think about and be innovative. You don't have to follow this exactly, but it's just to give an idea to the institutions according to their, and they have to come up with a way to do it according to their resources, whatever is available for them. But thanks for asking for my comment.
Thank you, Dr. Eman. So you can continue, Mahmoud. Shukran.
So last thing, we're going to talk about the how to put the personal protective equipment. It has to be done the same in the same sequence. So putting first the gown, then the mask, then the goggles, and the gloves. So here it shows how the proper way of putting the gown. It has to cover the torso from the neck to the knees. And then regarding the mask, it has to be fixed on the nasal bridge. And then for the goggles or the face shield, of course, this is important for us as we're in the delivery room or dealing with the body fluids and the blood. So this is really important. And lastly, the gloves. And then regarding how to remove the personal protective equipment, it has to be also by the same orders. First the gloves, then the goggles, then the gowns, and lastly the mask. And then we have to wash our hands or use an alcohol-based hand sanitizer. Just a comment regarding the gloves. If your hand gets contaminated during glove removal, immediately wash your hand or use an alcohol-based hand sanitizer. And also, just a quick comment about the gowns. The gowns, the gowns from the front and from the sleeves are contaminated, so avoid touching it from the front and from the sleeves. Unfasten the gown ties, taking care that the sleeves doesn't comes in contact with your body. Pull the gown away from the neck and shoulders, touching inside of the gown only. And this is the proper way of removing the PPE. That was my presentation. I hope it was beneficial. Thank you so much.
Thank you, Mahmoud. That was an excellent presentation. Allah ya'tik al-afiyah. So again, those last two slides, putting on the PPE is referred to as donning. Taking it off is referred to as doffing, donning and doffing. So you have to be all very, very familiar with this procedure in order to reduce any contamination. So thank you for the great presentation.
Yeah. Dr. Yasser?
Fadwah, Dr. Hythem.
Yeah, if you allow me, just to stress on the point that you mentioned, practicing donning and doffing is very crucial because it looks simple, but when it comes to practice, we misuse it. So just to remind ourselves about the steps. It's very important as you mentioned, and it's for protection, especially for the healthcare provider. It's very, very crucial to remember it. Thank you.
Thank you, Dr. Hythem.
دكتور ياسر.
تفضلي دكتورة سميحة.
أعلق بس على البرزنتيشن الجزء الأخير منها. الله يعطيكم العافية جميعا. شكرا دكتور محمود for the excellent presentation. I just want you to go back, if you don't mind, to the slide that you started with isolation and then home care. For pregnant women now who are with confirmed COVID-19, the standard for the non-pregnant, they're either in hospital or they're in hotels under infectious control, infectious disease consultant care. There are so far no confirmed cases, as far as I know, from the ID consultants that are sent home or managed at home. So when it comes to the pregnant woman, one has to be much more vigilant, and we have to calculate her risks in terms of the admission very carefully. So we would probably more likely to admit her because she's pregnant. So one has to be very careful with this statement with regard to pregnant women with confirmed COVID-19. Suspected maybe if there are no other comorbidities, but confirmed, then she has to be probably under direct care in a hospital.
Okay.
Thank you, Dr. Samiha. And just, just to make sure that we don't leave any questions unanswered, there was a question that was raised by Professor Nabeel regarding when to retest, PCR for those who were confirmed, and then, when we want to make sure that it's negative. So again, retesting, according to our infection prevention control department here in the National Guard, but it's probably similar elsewhere, the retesting is done every 72 hours. Again, so we should have 2 consecutive negative tests in order to clear a case that was confirmed. So we'll go ahead now with Dr. Sahar. Dr. Sahar, are you with us? If you can share your desktop, Sahar.
Yes. Assalamu alaikum.
Wa alaikum assalam. Can you share your desktop?
Yes.
Your presentation.
Assalamu alaikum. أنا دكتورة سحر حسين. I'm Dr. Sahar Hussein from National Guard Hospital, Jeddah. This presentation today is supervised by Dr. Yaser Faden. My talk will be mainly about COVID-19 guidance and patients in labor. So our outline for the talk today, care of COVID-19 suspected and confirmed cases in intrapartum and postpartum period.
Sahar,
yes?
We don't see your presentation. You didn't share your screen yet.
Oh, sorry.
No, that's okay. If you could just share your screen with us, so we can see its slides.
Now?
Yes, perfect.
Okay. I'll be talking about care of COVID-19 suspected and confirmed cases in labor, and anesthesia and surgical PPE concentrations, women with moderate and severe symptoms, medications and their effect on breastfeeding, and we'll summarize it up, inshallah. Attendance to labor and delivery. First of all, we should know patients with confirmed or suspected COVID in pregnancy. We should counsel them from antenatally that if they have any sign or symptoms of early labor, they should call their maternity care health provider or the maternity unit for further information and letting them know when to come to the hospital and the way of transportation. The patient, if she's coming through a Red Crescent, patient should inform the call handler of the Red Crescent that she's a suspect or a confirmed case of COVID-19, so that the person handling the patient and dealing with her should have done in full PPE according to the protocol and standard protocol, and the patient herself will be wearing a surgical mask. At the hospital entrance, before the patient enters the hospital, patient need to be assisted by a maternity assistant doctor or nurse wearing a full PPE also, and the patient will be transferred to isolation room wearing her surgical mask. All women, so according to the RCOG recommendation, all women should encourage to call the maternity unit, as I mentioned, for advice in cases of early labor. If birth at home or a midwifery-led unit is planned, we should discuss with the patient the potential risks of fetal compromise, giving the evidence we have that we have 20 patients confirmed cases of COVID-19 in pregnancy. 8 of them had a case of fetal distress. In light of that, we should inform the patient that if she is going to have a home birth or a midwifery-led unit, that she needs to be on continuous CTG in light of the risk of fetal distress. Labor and delivery. Once the patient is settled in an isolation room, as I mentioned, and transferred with a doctor, will assess the severity of the COVID-19 symptoms involving medical and infectious care on board. So once the patient arrives, we'll assess her symptoms. Is she mild, moderate, severe, or critically ill? Is she already following with the infectious disease, or she is a suspected? If suspected, we'll take swabs and we'll put on board the medical doctors with us and the ID doctor. Vital signs will be checked and will assess her in labor and her labor progress as per standard protocols, as normal as we are following a patient in labor and assessing them. CTG will be done continuously. If a woman showing any sign or symptoms of sepsis, like she is having a history of prolonged rupture of membrane, she is febrile, we do not also having other differential other than COVID in her situation, and she will be treated accordingly. According to the Saudi Society of Fetal-Maternal Medicine, they highlighted some points regarding the ibuprofen, since endomethacin is like ibuprofen, it's from the same category, it's non-steroidal anti-inflammatory drugs. Endomethacin will treat it in pregnancy as the ibuprofen. They witnessed on cases they used the ibuprofen in young patient in early disease that it showed a severe disease when it was used in the early of the illness. From that point of view, endomethacin, they advise that should be avoided as a tocolytic. Nifedipine should be used as an alternative tocolytic in cases of preterm labor. Regarding the dexamethasone, there is a little of contradictory between the Saudi Society of Fetal-Maternal Medicine and RCOG. I will review all, I will show all. Dexamethasone should be used cautiously, as dexamethasone, they are treating it as the steroid. So from the point of view of the steroid analysis, they found that the steroid affected adversely the MERS type of coronavirus and helped with the SARS type. But in cases of SARS-2, which is COVID-19, they found that it's prolonging the viral pneumonia period and worsening the symptoms. So from this point of view, the Saudi guidelines, they stated that it should be used cautiously, and especially will individualize the cases if we are dealing with the critical or severely ill patients. Due to the lack of evidence in cases of progesterone, in case of preterm labor, we can continue it in the case of mild disease. Magnesium sulfate also as a part of being treatment for preeclampsia or preterm labor for neuroprotection. In both these 2 points, magnesium sulfate, we should keep in mind that it is excreted by the kidney and it might have respiratory side effects. So it should be used cautiously when we are dealing still with severely ill or critical patients. This is just an algorithm about the management of pregnant women suspected or confirmed COVID, but this algorithm for patients not in labor. So once the patient arrived to the hospital, as I mentioned, the patient will be handled and reach the isolation room, negative pressure room, wearing her surgical mask, and the person handling the patient wearing a full PPE will pass through the PPE in a few seconds. The patient should be admitted to a negative pressure room. Multidisciplinary approach should be conducted. ID, MFMU, consultant, obstetric, NICU, anesthesia, and ICU team will be on board. The patient will be assigned to a negative pressure room, and if she is severe or critically ill, she will be assigned to negative pressure room in the ICU. If the patient is having mild to moderate disease and she is not in labor, we'll adhere to the PPE, the practice. We'll review the patient obstetric history and risk factors. If she's in an age of viability of pregnancy, we'll do for her the NST. The others, the measures like growth scan and biophysical, it will be done as per obstetric indications. But some things, the unurgent things like morphology scan or first trimester scan can be deferred until the patient is completely cured or cleared from the virus. Supportive measures will be conducted: hydration, antipyretic, as I mentioned, ibuprofen and NSAID should be avoided as possible. Termination of pregnancy in case of mild to moderate disease is not an indication as long as the maternal and fetal conditions allows the continuation. If we are dealing with severe or critically ill patients, they are not in labor, we'll adhere to the local infection protocol, stabilizing the patient, and we'll keep in mind that the priority is always for the maternal well-being. We'll review the patient's obstetric history and important risk factors. If pregnancy reaches the viability, we'll do the NST and ensure fetal well-being. The fetal surveillance scan can be deferred until the patient is allowed and cleared and she's stable. Consider pregnancy termination if this pregnancy termination and the delivery will improve the maternal health and condition. This is the context if the patient is, what I mentioned, if the patient was not in labor, okay? If the patient is labor, suppose I saw the patient and then reviewed her after 2 or 4 hours and she's progressing, then we'll start doing a vital sign check. We'll do hourly oxygen saturation measure. Our aim is to keep the oxygen saturation above 94%. We'll minimize the number of staff entering the room as much as we can, and senior person will lead the handle and dealing with these patients as they are considered high risk. No evidence to favor the mode of birth, and this if the patient is from antenatal visit, we can explain it to her from that time that the delivery for cesarean section, it's only considered for obstetric indication or for maternal respiratory condition only. No contraindications to epidural or spinal anesthesia. Mentioning that there is no contraindication, it's the Saudi Society for Fetal Maternal Medicine advised for epidural and spinal anesthesia as a backup. If the patient is going for a cesarean section, patient will have the anesthesia and will not need the general anesthesia if in cases of emergency. No evidence that the Entonox is an arousal generating procedure. Entonox is the nitrous oxide. This is what I'm displaying now. It's the RCOG recommendations. From the RCOG recommendation, the Entonox is not an arousal generating procedure, so it can be used with the patient and the equipment will be disinfected according to the standard protocol afterward. The PPE will be done as protocol. I will show you the difference between the PPE in the RCOG and in the Saudi Society in minutes. So if patient in labor, according to the Saudi Society of Fetal Maternal Medicine, the distance between the healthcare provider involved in taking care of the patient, it will be less than the standard distance. It will be less than 1 to 2 meters. So in this case scenario, a full PPE is recommended. Presence of support person intrapartum is not encouraged. And if allowed, we'll ask the person to do a full PPE and assign a risk of exposure consent. This is if the patient, if we are requiring a support person intrapartum. According to the RCOG, support person intrapartum, if he is or she is asymptomatic, can be allowed to enter, but we'll ask them to do frequent hand hygiene. Saudi Society also of Fetal Maternal Medicine state that the PPE should be applied by standard protocol. The N95, which is considered an airborne precaution, when it's used by a healthcare provider dealing with any confirmed or suspected COVID cases. If I'm dealing with a confirmed or suspected case, I'll be wearing in every encounter when I'm seeing the patient the full PPE in form of gown, and N95 mask, and face shield or goggles, and the gloves. So in this case, the N95 will be used. Also, if I'm dealing with arousal generating procedure, including the second stage of labor, they included it in a arousal generating procedure like circumstances. We'll avoid use of fetal scalp electrode if possible, and the patient should be on continuous CTG externally. COVID-19 is not an indication for cesarean section, and we mentioned already that the indication is only fetal condition or obstetric indication and a maternal respiratory condition. Surgical team should wear N95 respirator with the regional anesthesia, as there is a risk of converting to general anesthesia. Here, this is a recommendation by the Saudi Society that surgical team should be wearing the N95 respirator when dealing with regional, as there is a risk of converting to general anesthesia. From RCOG guidelines, they stated that the person can wear the fluid resistant face mask if I'm conducting regional anesthesia by cesarean section, as the risk of converting to a general is very minimal. We'll delay the elective cesarean delivery as possible until the patient is cleared if we can. And if we are doing the cesarean section on the list for COVID confirmed or suspected patients, we'll put it at the end of the list so the OR will be disinfected properly per standard protocols. Any questions till now?
Any questions or comments?
شايف أحد رافع يده في أحد حاطط أسئلة.
Excuse me, I have a question.
Yes, can you ask?
I'm Dr. Yasmin, R4 resident in SCFHS. I want to ask Dr. Sahar or anyone can answer this question about the N95 or surgical mask. When, like, if I'm dealing with confirmed case or suspected, I have to wear the N95. How about in general, being in the hospital, do I have to wear the surgical mask all the time? Or it's okay just when dealing with someone who is suspected?
Can I answer?
Dr. Sahar, yes?
Yeah, thank you for your question. Regarding the surgical mask universal wearing, it's recommended when you are dealing with in patient's encounter. So if you are encountering a patient in a clinic or in a labor room setting, we will use a universal mask wearing, because there is a part of patients who are asymptomatic and they are COVID positive. We don't know that. But in case you are like working in a hospital setting or going in or out of the hospital, as you are not in a close proximity of a person, you should not be wearing the surgical mask.
The question of Dr. Yasmin was for N95, right, Dr. Yasmin? Well, you're talking about surgical mask.
No, in general, surgical and N95. Thank you, Dr. Sahar. It was clear from your presentation that N95 is direct contact with a confirmed or suspected case. But in general, if we're dealing with any case, any patient, yes, we have to wear the surgical mask.
Yes.
Yes.
Correct. I agree.
Yes.
Yes, I agree with Dr. Sahar that this is the precaution that we need to take. Surgical mask whenever you're dealing with any patient in any clinical area, and the N95 only with confirmed cases. Yes.
Shukran, Dr. Hythem. Any other comments before Dr. Sahar continues?
Yes.
Yes. One more, if you allow me, Dr. Samiha. Dr. Sahar, in her lecture, nicely she mentioned recommendations from both the Saudi Society and the RCOG, and probably you may find some differences still from UK or from Saudi. The evidence is still lacking. Most of these recommendations are expert opinion because we don't have strong evidence on those recommendations. So we whatever we said in our or some recommendations in our guideline were based on extensive discussion and expert opinion. Probably that's why you might find some differences between recommendations. But in general, we depend on that. Yes, thank you.
Yes, so Dr. Hythem, he mentioned a very important point that sometimes you might find, different opinions from one guideline to another. Know that, all the recommendations that are given in different guidelines are based on expert opinion. So it is the weakest level of evidence, but at the same time, it is considered the best available evidence. So there has been, extensive discussions amongst the task force committee of the society. I think the recommendation was based on the experience in our own setting here in Saudi Arabia. So probably recommendations that were given by the Royal College or by or the ACOG is based on their clinical settings there. Our recommendations are based on our experience and what we know of our settings here in Saudi Arabia.
Yes, and one more thing, Dr. Yasser, if you allow me. We also try as much as we can
إذا
to match
ممكن
the
الباقيين
national.
بس يحطوا الميكروفونات ميوت بس اللي يتكلم لأنه بيسوي صدى.
One second. I'm going to mute you all. And now, Dr. Hythem, if you can unmute yourself and then talk, please.
Yes, please. Just one more thing, and also on top of what Dr. Yasser said, also that we also looked after our national strategy and goals. So we need to match our country and governmental recommendations with our policy and practice. So that's why we also probably we seems more cautious, but because the whole attitude and the whole directives are like this. So that's why probably you may see that we are giving some advices that taking extra cautions. Probably that's the reason.
Thank you, Dr. Hythem. Now I'm going back to the chat. I noticed there were some questions because it's difficult sometimes to host, and I'm still admitting people, and at the same time I'm trying to moderate. So there were some questions here regarding, for example, somebody asked about Sarah, asked about اللي هو اللثام اللي هو الغطوة الظاهر أو الحجاب or covering the face. Should we stop that and wear a surgical mask instead? So any of the experts would like to tackle that question?
Actually,
yes, Doctor. Hello, مين? Hello.
الو
ايوه مين معايا؟
دكتور ياسر.
ايوه دكتوره فدوى اتفضلي.
They are all recommending now because they have recent reduction of masks, so they ask for.
دكتوره فدوى if you can go somewhere يكون الإرسال قوي لأن الصوت بيتقطع فالصوت غير واضح. الصوت لسه بيطلع دكتورة فدوى، الصوت غير واضح.
طيب, until if you allow me, until Fadwa can find her good spot for talking, the CDC had actually issued a new recommendation to use cloth mask to block the spread of COVID-19. And I don't think there is a reason to change covering the face with your ghutwa or hijab if you're not directly contacting the patient. But if you're walking in the hospital or you're in a clinic and you're not directly contacting with a suspected case or confirmed case, then that should be okay. If you're going to see a suspected case or confirmed case, then you have to take off your hijab, you have to wear your full PPE as recommended, with the mask, with the face shield, with the goggles, with your double or your gloves, and your like the Dovin and everything with the PPE. That's what I think so far. So we're gonna wait for what Fadwa has to say as well.
Okay.
Now?
Yes, Dr. Fadwa.
Okay, so Iman, this is exactly what I want to say is regarding the last version of CDC. To say.
طيب, okay. So,
ياسر اسمح لي بس تعليق ممكن؟
تفضل دكتورة سميحة.
أنا راح أرجع أعقب على كلام الدكتور هيثم بالنسبة للدiscrepancies, which I totally agree with you that there are some discrepancies based on our situation, based on our government leadership, and based on the fact that many of the recommendations that are done by other societies are based on cost effectiveness, as mentioned a while ago by Prof. Khalid, that cost effectiveness played a big part in things. And that goes as well with the CDC recent recommendations. They're shy from saying use surgical masks basically because they're not available. So based on that, they're changing that to saying, well, use a cloth mask. So one has to understand that our expert opinion was based on giving the medical opinion regardless of the cost. We might reach, we are all short of PPEs, and we have to use them wisely. That's why I agree as well with Dr. Fadwa, with Dr. Eman, that when it comes to patient direct encounterment with confirmed or suspected cases, yes, absolutely surgical masks. So we need to just observe that the local guidelines are based على التوجه العام حق الدولة our expert opinion again.
Thank you, Dr. Samiha. There was another question, if Sahar, you can answer this, or one of our experts here. When you spoke about the support person coming in with a patient in labor, there was a question: does the support person also have to use the PPE?
Yes. Thanks for the question. Regarding the support person, according to the Saudi Society of Fetal Maternal Medicine, we should explain to them the risk of exposure, and they should sign a consent that they are agreeing that they are having the risk of exposure, and they should be asymptomatic so they can attend the delivery, and low risk if we have done the visual screen on them, and they will do complete PPE.
Thank you, Dr. Sahar. And again, Dr. Eman in the chat, she mentioned again, she just confirmed regarding the frequency of sampling, again, should be at least every 2 to 4 days until there are 2 consecutive negative samples, at least 24 hours apart. This is according to the MOH guideline on COVID-19. Yeah. Thank you, Dr. Eman, for that. Again, there was a question about giving enema prior to labor, since we talked about the fecal possible passage of the virus in the fetus. So, so what do our experts here think about giving enema? Should that be, should we allow enema to be given? I mean, any restrictions to that?
we discourage it in the normal circumstances. And in this situation, especially in the pandemic of COVID, I think we should stop this habit, because there is a growing evidence now showing that COVID-19 virus has been isolated in the stool. So we discouraged using plate enema in general, and particularly in this situation now. I don't know if my colleague agree with me with this. That was a good question, actually.
Yes, excellent question. Any other opinions?
I agree with Fadwa. I think that first of all, it's not part of the preparation for labor.
Exactly.
It has no benefit apart from convenience for the medical staff, but we might actually make the scenario worse, because the enema might not work immediately at the time, and then during labor she would have the fecal material. So I think it's better to leave it to her, leave her without enema. If she passed stool, just be as careful as much as possible. You're going to have to be wearing your protective equipment already, so just be vigilant.
Okay, thank you, Dr. Samiha. And one last question before we let Dr. Sahar continuing. The question was asked by Dr. Alama Sharif. Isn't the person that will be exposed to the patient should be a senior obstetrician? So this is another important question. So when we're having patients coming to labor and delivery or anywhere else in the hospital, who should be attending to that patient?
So if you allow me, Yasser, if the hospital have a maternal fetal medicine, then the patient should be under or cared for by the maternal fetal medicine. If we know that they're not available in every hospital, if isn't available, then the senior obstetrician, in my opinion, should care for that patient. But if we say that, then we have to know who are high-risk patient or population, or high-risk population who are at increased risk of complication of COVID-19. And if we say senior physician, are we talking about physicians who are older than the age of 60, where they're vulnerable patients, or or vulnerable population who are older than a certain age? I don't know the correct answer for this, honestly, but I'm going to leave it for the rest to. It's a controversial thing.
Assalamu alaikum. Do you mind? Just keep in mind, we always try to minimize the number of physicians.
Yasir, just Dr. Yasir Katib is with us now. Tfadal, Dr. Yasir.
Shukran, Dr. Yasser. So just to remember that we are trying to minimize the number of healthcare providers, as well as not only the visitors and accompany people, as much as we to at least number can do the job for us. So it's better if we can the same person who's going to be involved from the beginning to the end. So it's especially we are dealing with sometimes we might have to intervene with emergency cesarean or something. So it's better to have the senior person there who's most responsible, as Dr. Eman has mentioned. Yes, he has to be there by himself. In addition, if he needed assistance maybe for the surgery, but for the normal vaginal delivery, probably the least number possible would be the best.
Yes, so basically, if we're dealing with these patients, COVID-19 suspected or confirmed, they're admitted in the antenatal ward, meaning they are not in labor. Usually, these patients would be taken care of by the maternal fetal medicine specialist, and if not available, then of course by obstetricians who will be able to manage these patients. So if we're talking about patients admitting to labor and delivery room, they're in labor, then they need to be attended by the most senior obstetricians available. So meaning if the consultant is going to be in-house, then the consultant or the registrar or a senior resident as much as possible, because again, we want to minimize exposure of or having the least number of our staff exposed to these patients as much as possible. So it is recommended by many centers around the world that these patients are attended by the senior physicians.
One more comment.
Yasser, طبعا كل الeffort is focused on reducing the number of exposures when people exposed to the patient. In my opinion, the one who is going to make the decision is the one who should be first.
Exactly.
Because if I'm like a resident or a senior resident, I go and examine the patient and I cannot decide for cesarean or not, I shouldn't see her.
Yes.
One who is going to make the decision is the one who should see the patient first and should follow the patient till the end. This is my opinion.
Thank you, Prof.
Doctor.
It's short and to the point. Shukran, Prof.
Dr. Yasser.
Yes.
يعطيك العافية, Prof. I totally agree and support with your comment. Plus, Doctor, I think also it's the responsibility of the most senior person in the labor room or in the clinical area to make sure that whoever is going to examine the patient is taking all precautions, and they are trained on this. They know how to do donning and doffing. They are already did the fit testing for N95, so to make sure their safety is taken care.
Thank you, Dr. Hythem. Now we'll proceed ahead with the presentation. I noticed there are more questions coming, but we'll delay them until Dr. Sahar completes her presentation. تفضلي Dr. Sahar.
Okay, thank you. I just want to mention that I don't know who is drawing on my slides, so please don't do that. I will be talking now about...
I thought that was you, but yes, please, be careful that everything you write on the screen is going to show to everybody. So,
I'll be talking about the personal protective equipment, the PPE in labor. This is according to the RCOG. RCOG recommended that when we are dealing with a patient's confirmed or suspected COVID, we are going to implement a contact and droplet precautions. That means if we are conducting a vaginal delivery, then the doctor should be wearing a gown and then face mask, surgical face mask with the eye shield and face shield and the gloves. If the patient, as they are considered considered the labor and pushing is not an aerosol generating procedure. The only aerosol generating procedure which will require doing an N95 mask use is the general anesthesia and intubation during cesarean section. Other than that, it's not considered like this, which is also contradicting with the Saudi Society, which state which Saudi Society guidelines like recommendations, they are reasonable as the distance between the doctor and the patient itself in even while conducting vaginal delivery is less than the standard distance. So we should use the use of N95 even in the second stage of labor. PPE in case of vaginal birth, as I mentioned, according to the RCOG, is the gloves, gown, fluid-resistant surgical mask, and a visor to protect the eyes. PPEs for cesarean section, if intubation and general anesthesia is required. So if we are in the labor room and we have an emergency or crash emergency cesarean section, we should counsel the patient and the relative attending the delivery that there is a risk of having a delay in conducting the cesarean section till the staff will do the proper donning of the PPE. The patient itself will be informed about that risk. To decrease this thing, we should encourage the resident and the doctors and the staff to practice the PPE, show they shortens the time for doing the PPE, and also to increase their confidence in dealing with these situations. So in cases of general anesthesia, according to the RCOG, all staff should wear the filtrating face piece level 3, which is the N95, and surgical team should scrub and do the PPE before general anesthesia initiated. If the cesarean section is done under regional anesthesia, then all staff not required for a regional anesthesia should stay out of the theater all staff in theater will do the PPE with the fluid-resistant mask, as according to the RCOG, the risk of converting to GA is minimal. According to the Saudi Society, again, because the risk, there is even if there is a small risk, there is a risk of converting to GA, so it's should consider wearing the N95 for all the surgical team. Regarding the general anesthesia, the doctors and the doctors who are gonna scrub in the OR, they have to do the PPE before the general anesthesia and the intubation initiated by women with moderate or severe symptoms. This is a special consideration and category. As we mentioned, it's all a multidisciplinary team approach. We'll discuss with in the meeting with the multidisciplinary team, the patient's severity of the disease, the role of the medical care in this situation, and the most appropriate location to lead the specialty. So if the patient needing ICU, so we'll conduct the ICU and prepare the ICU. If the patient is in labor, we'll prepare the ICU room to conduct or even the delivery. Condition of the baby should be taken in consideration, and the priority is always for the mother, and the specific care if ICU is needed. So we'll keep a low threshold for ICU if we need them, and the low threshold for cesarean section if indicated. This is especially with the moderate and severely ill patients. Regarding the radiological investigations, we'll perform it as we are performing it for a non-pregnant woman as we need them. So if we are requiring a chest X-ray or chest CT, and it's ordered by the medical doctor, it should be done with an abdominal shielding. Consider additional investigation to rule out the diagnosis like ECG, echocardiogram, full septic screen to rule out other differential if you are keeping in your mind that there is another differential, sepsis or heart failure or kidney injury, will deal accordingly. Caution with IV fluid management, and we'll make sure that the patient, she is not going in a fluid overload. We'll do an intake, input and output chart, and we'll review it. Consider both maternal and fetal well-being. As Anna mentioned, the priority is always for the mother. There is no evidence to suggest that steroid has a harm on context of COVID. So according to the RCOG, it can be used for fetal lung maturity. This is also area of discrepancy, as the Saudi guideline stated that it should be individualized in cases of severe and critically ill patients, according to the evidence they have that it prolongs the viral pneumonia in patients with COVID. This is just an algorithm about the management of pregnant women who are in labor. As I mentioned, multidisciplinary approach is always done, including the ID, MFM, obstetric consultant, NICU, anesthesia, and ICU teams. Patients with mild to moderate disease will be admitted to a negative pressure room in labor room. And if she is severely or critically ill, she will be admitted to ICU in a negative pressure isolation room equipped to conduct delivery. This points which I'm gonna mention, it's gonna be applied to all the patients, mild, moderate, severe, and critically ill. They should adhere to the standard infection control practice. Will stabilize the patient, as we mentioned, always the priority on the mother for the mother in cases of severe disease. Will review the patient obstetric history and determine the gestational age and risk factor, and will do maternal monitoring. Monitoring means we'll monitor the vital signs, the oxygen saturation hourly, and will do fluid balance, continuous external fetal heart monitoring to ensure fetal well-being, and will avoid the use of the fetal scalp electrode due to lack of evidence about its safety and viral transmission. Labor pain control, opioid can be used, the narcotics with caution based on the respiratory condition of the mother. According to the Saudi Society guidelines, again, nitrous oxide not recommended in this situation to avoid the contamination. According to the RCOG, it can be used and the equipment will be disinfected accordingly after. If mild to moderate labor, mild to moderate disease in labor, will our main goal is shorten the second stage, will shorten it with the instrumental delivery might be considered. Active management of third stage of labor done according to the obstetric indications. Will avoid a mother direct contact with the baby, avoid skin-to-skin contact, and in cases of mild to moderate disease, this gonna follow the hospital and the local institute protocols in the direct mother skin-to-skin contact. And newborn separation from the infected mother, is it a reasonable option in mild to moderate disease? And also it's gonna follow the local institute protocol. According to the RCUG, if we are gonna post-delivery, the literature review from China, they advise to isolate the mother from the baby for 14 days. And RCOG stated that if the patient is with mild disease and she has no symptoms and baby is fine and cleared by the pediatrician, there is no harm of explaining to the patient the risk of exposure and also the benefit of bonding, and the patient will have the right to decide upon that. If we are dealing with severe or critically ill patients in labor, vaginal delivery is preferable also, and epidural and spinal is preferable also to avoid the need for general anesthesia. We shorten the second stage of labor with instrumental delivery, it might be considered. Active management also of third stage of labor, it's on individual basis. Newborn, according in severe or critically ill patients, according to the Saudi Society, newborn should be separated from critically ill mothers. Any questions till now?
Yes, please, Dr. Sahar. Regarding the delay cord clamping in suspected or confirmed COVID-19, supposed to be done or not?
Yeah, there is no like nothing against delaying cord clamping. So delay cord clamping, it's recommended even in COVID-19 patients.
Thank you.
Welcome. Any other question before I proceed to therapy?
Questions or comments by anyone?
Hello, this is Dr. Shireen from Bahrain Salmania Medical Complex. According to the Chinese literature, they said that the baby should be isolated for 14 days. Is the mother allowed to breast pump and they can feed the baby via the breast milk? Or
we'll explain this point in later on in the slide, and we'll answer your question, inshallah.
Okay, thank you.
Welcome.
Sahar, I think you can go ahead and complete your presentation, and then we'll address any questions at the end. Thank you.
Okay. Regarding the COVID-19 therapy in pregnancy, first of all, these therapies all are like used, and they witnessed by using that they have a good impact on the COVID-19 control and clearance and clearing the virus. First of all, the first line is chloroquine, hydroxychloroquine with azithromycin. As we know, we'll go back that the COVID-19 or SARS-2, it is an ACE2 receptor. It enters the cell through the ACE2 receptors. So the benefit of hydroxychloroquine is that it's an ACE2 receptors blocker. So it stops the binding of the virus to the cell. That's like the theory behind why it's working on COVID-19 patients. So the study showed that it's associated with the reduction of the progress of the disease and the duration of the symptoms. They have done one open label study on 36 patients, used 200 milligram TID of hydroxychloroquine for 10 days, and compare it with no specific treatment group. They found that 70% of the patient had an undetectable virus on nasopharyngeal swab on day 6 from the initiation of the treatment. Compared to no specific treatment, the negative swabs were about 12.5%. This shows how effective is the treatment in regard of COVID-19. I have to highlight that all medications will be started by the ID and medical team, and they will decide according to the patient's status when and when not they will start these medications. Hydroxychloroquine, it has various regimens. For us as an obstetrician, it's good to know the dosing and the side effects, but most important is to know the safety in pregnancy and with lactation. This is very important for OBGYN. So considering the safety of use in pregnancy, it's reasonable to apply it as a non-pregnancy patient. It's considered category C in pregnancy, and it will be used as the patient needed. So if the patient needs the treatment, we'll give her the treatment. The regimen used is 400 milligram BID on day 1, then we'll reduce it to 400 daily for 5 days, or 400 milligram BID on day 1, then it will be 200 BID for another 4 days, or we'll start with the 600 BID on day 1, then 400 once daily for 4 days. Antiviral treatment, mainly protease inhibitor. It's used in China mainly to treat the moderate and severe patients, either in conjugation with the hydroxychloroquine or separately if the patient has contraindications to hydroxychloroquine. The regimen used is lopinavir and ritonavir, 2 capsules, 200 milligram, 50 milligram per capsule. It will be taken with a nebulized alpha interferon inhalation twice daily. This will be done for 7 days. Statins, it's contraindicated in pregnancy. It's category X in pregnancy, so we cannot use it on pregnant patient. But as we know, a statin, it's an ACE2. It works on an ACE2. It upregulates the ACE2 activity in the body, so it will bind to the ACE2 receptors and reducing the binding of the virus to the cells. So it will reduces the severity of the acute respiratory distress. Regarding the antibacterial treatment, it's only used if a secondary bacterial pneumonia developed. Empirically, we can start the ceftriaxone until the culture and sensitivity results come out. Regarding the glucocorticoids, there is no good evidence on their benefits. And as I mentioned, from the risk of the steroids on the SARS-2 and prolonging the viral pneumonia, it's not used much in pregnancy. Supportive therapy, of course, rest, hydration, and maintain nutritional support. And antipyretic, we mentioned the first antipyretic to be used is the paracetamol, and NSAID should be avoided to be used for temperature control if we can use the paracetamol. So WHO recommended that NSAID be avoided, recommended that we don't avoid NSAID use when it's clinically indicated. So if it's clinically indicated, we can use the NSAID. Regarding postnatal care and breastfeeding, this is RCOG recommendation again, and we'll mention the Saudi Society also recommendation in a few seconds. RCOG recommendation, as we mentioned, they reviewed the literature of China, and they advised, according to the literature from China's studies, they advised to isolate the mother and her baby for 14 days. Infant feeding, the main risk is from contact with the mother. So we'll discuss with the patient that the risk of close contact and the risk of shedding the virus to the baby we can ask the mother clearly that there is a risk, and she will decide if she wants to breastfeed the baby naturally. We can also inform her about expressing breast milk, and she can ask someone else to feed the baby in that situation to reduce the exposure of the baby. This is according to the RCOG recommendation. According to the Saudi Society of Fetal-Maternal Medicine, first of all, because the patient is passing through a disease, and she will have to stay away from the baby for 14 days, and so she is a higher risk of developing postpartum depression. So we should do screening for postpartum depression scale, and we should provide them with a psychological support. Standard contraception counseling will be provided for the patients. Infant born to mother with a COVID-19 should be considered suspected cases, and they will be isolated as per Saudi Ministry of Health guidance. Direct breastfeeding for Saudi society, they do not recommend due to the close contact with the mother. We can explain to the mother, and we do counseling about breastfeeding risk and benefit, and the risk of exposure to the baby. Until now, there is the studies done, there is no available evidence that it is expressed in the breast milk, but there is a risk of being close to the mother. In this context, the patient will decide and will write an informed discussion about the patient and her choice. We should allow her either for expressed breast feeding or formula milk, and if she gonna use formula milk, we can give her medication to suppress breast milk production. Medication with lactation. We know that hydroxychloroquine is safe with lactation. It's only with the pregnancy. It shows fetal ocular toxicity reports. No evidence on effect on the lactation for hydroxychloroquine. The problem is with the chloroquines sometimes and the antiviral therapy that it can cause anemia, hemolytic anemia in the newborn. So in form of G6PD deficient infant and premature infant, we discourage breastfeeding in that circumstances. This is all. I'll pass now by summary of what I have mentioned all. Till now, any questions?
I think you can continue. Sahar, finish the presentation, then we'll take the questions at the end.
Okay. For summary, this flow chart is from the RCOG recommendation. Flow chart to assess COVID-19 risk in maternity attending unit. So we'll see the patient. Does she have any, like she is fitting the case definition, or having symptoms of cough, fever, or a temperature above 37.8. If she has no symptoms, no further action will be taken. If the patient has symptoms, then we'll give the patient a surgical face mask, and a full PPE will be done with the person is in contact with the patient. Then we'll assess the patient. Is the patient in labor or is she is not in labor? We'll isolate her in a negative pressure room if she is a high risk. We'll do swab if she is a high risk. If she is already confirmed case, we'll put on board the obstetric, the midwifery, and the ID and medical doctor. So if she is not in labor, we'll assess the patient and will be evaluated by the medical team prior to discharge. We'll advise her for home isolation for 7 days if she is suspected or having flu symptoms, and we'll rebook her appointments as we can. So if she have any urgent appointment, she can rebook her appointments later. And if she is in labor, we'll follow the chart of labor. She will be admitted and we conducted the delivery as we discussed earlier. Regarding this is just to summarize how to deal with patient in outpatient setting, inpatient, and labor and delivery. I think labor and delivery, we explained it thoroughly. An inpatient team will manage all antenatal patients who will require the admission and will involve the other specialties as needed. As a multidisciplinary approach, we should also enhance the discharges from the unit so we can reduce the patient's number and reduce the exposure. So we'll do ERAS, the enhanced recovery after surgery protocols, to discharge the patient. For outpatient team, Dr. Mahmoud explained it very well. We'll categorize the patients in clusters. If the patient is a confirmed case of COVID and she needs to attend the clinic, we'll see her in another setting. So she will be seen in an isolated area. If she needs ultrasound, will you do for her the ultrasound? Then equipment will be disinfected. We'll postpone the essential ultrasound until the patient is cured. And if she's a low risk, to go to primary healthcare to reduce the load on the tertiary centers. I think that's it for COVID-19 guidance. Now, if these are my sources, RCOG guidance and up-to-date Ministry of Health and Saudi Society of Fetal-Maternal Medicine. Lastly, I just want to say stay home and save lives. If you have any questions, now the floor is open for discussion.
Thank you, Dr. Asqar. But I don't know, we as physicians, should we stay home or we have to be in the hospitals? Okay.
Exactly.
But anyway, we got the message, yes. So, as much as possible, we can stay home. But if we have to be working or covering a shift or whatever, then we have to be in the hospital. Thank you, Sahar, and thank you, Mahmoud. There were excellent presentations, and I think you covered everything. I'm going to open the floor now for comments first by our MFM experts. So if any of
Yasser, I do have a comment here, if you allow me, please. Can you hear me, Yasser? If you allow me, I do have a comment here.
تفضلي Fadwah.
Okay. So first of all, it was really excellent and very informative to the point presentation, Sarah and Mahmoud. I really enjoyed your presentation. My comment is regarding the 3 short for cesarean section. As we all mentioned clearly that COVID-19 in pregnancy is not an indication for cesarean section per se. However, our 3 short for cesarean section has to be low. And why is that? Because as simple as there is no such a crash cesarean, there is no such an emergency cesarean, especially for fetal reason. And by the time the managing team is wearing the PPE and protecting themselves, because this is #1 priority as a health care provider, we have really to protect ourselves to be able to help the patient. By the time you are wearing your PPEs and protecting yourself, that's gonna take about at fast 15 minutes, if it is not taken up to 25 minutes or even 30 minutes. And by the time you are pushing the patient to the OR and open her up for a bradycardia or cord collapse, I think the safety period to save the baby, we will be jeopardized. So that's why I think I add my voice to Dr. Nabeel that the person who can make a decision should be involved in this case. Why? To make sure if there is, like I said, the 3 short for cesarean section in this conditions has to be low. For that reason, we mentioned in our guidelines that fetal scalp electrode is discouraged, not only from the point that we don't have enough data for the transmission, but also if you reach to the point that you want to do a fetal scalp sampling, cesarean section is actually recommended here. So that's my comment in that part. Thank you so much, Dr. Yasser.
Thank you, Dr. Fadwah.
تسمح لي دكتور ياسر لو سمحت.
تفضل دكتور ياسر كاتب.
Just for everybody, these guidelines were put for as an ideal way, or the best way to do it. But we recognize there are some limitation of resources in different hospitals. And so, for example, no negative pressure room in delivery room, no face shield available in that hospital. So our job as a residents or everywhere to convey the message to all our seniors, not necessarily probably they don't know in everybody hospital, they are aware of what is the ideal situation for protection for ourselves. So I hope that everybody convey the message to the hospitals about what is ideal, and they work on this before actually we got a true case and come to our doors, either because they are coming late in labor, you cannot do much about it. Then we say there is no available data and everybody gonna throw no available protection, and everybody gonna throw the patient to the next one. So just be aware that we should be part of the encouraging this educational process, everybody. Thank you.
Yes, so again, the importance of having obstetric drills. Yes, so Dr. Samiha Alawami.
يعطيكم العافية جميعا. أنا حابة أشكر المتحدثين حقيقة على وضوح المحاضرات، concise to the point. يعطيكم العافية، ما قصرتوا. وأضم صوتي لصوت الدكتور ياسر كاتب إنه هو this is guidance، واجتهدنا فيها قدر الإمكان بناء على الأدلة اللي موجودة حاليا. الأدلة العلمية اللي استندنا عليها هي الأدلة العلمية الموجودة حاليا. وزي ما شفتوا إيش صار في RCOG، بدأوا بالنسبة للبريست فيدينج، وبدأوا بالنسبة للآيزوليشن إن هم the baby should be nursed with the mom، ودحين غيروا رأيهم إلى مع أنهم كانوا الوحيدين. يعني كان ال Chinese literature they recommended separation، ال CDC الأكد they recommended separation، we recommended separation as well. فهذا علم متغير على حسب المتغيرات اللي قاعدة تصير دحين في الأبحاث العلمية الحالية. لازم نتذكر إن إحنا خلاص إحنا اليوم أخذنا المحاضرة وتعلمنا كل اللي فيها، بس بكرة لازم نقرأ الأدلة الجديدة اللي تطلع. فلازم الواحد all the time we should be updating ourselves زي ما إحنا we're going إن شاء الله to update our guidelines.
Yes, and I would like to let everybody know that we have already started the process of updating the guidelines, because the guidelines, I mean, there is new evidence every single day. So we have already started that process. Prof. Khalid, you have a comment?
Yes.
Yes, thank you, Yasir. First of all, I just want to say that, I've been working on the guidelines all my life in the Royal College, and the way and the time you've taken to produce these guidelines must be applauded. It's actually one of the best things done ever. I cannot actually raise it more. Thank you very much for that. And yes, it needs re-updating. Just 2 points. One of them, just to add to the point of minimizing people, the issue of episiotomy. If there was an episiotomy, I don't want to go into who should have it or who shouldn't, but some of the nearby hospitals here, I know all of them, and they were talking, of course, we talk all the time about this COVID-19. They abandoned junior midwives, junior doctors of suturing any episiotomy at this time. Not for, all the time, just for this critical time, because that will minimize the people, the individuals who are there. Because, if, for example, resident 1 or 2 gone there and he or she needs help, somebody else will come, and then, so they limit that now for a registrar and above. So that's a very important issue. The other thing, the practice in UK is different, of course. There is usually early discharge, 4 to 6 hours after delivery. Now, certain hospitals here, they are minimizing that to 2 hours only. And I'm not quite sure, whether this will be applicable to our population in Saudi Arabia or not, but it's something to think about. Sahar did mention correctly that, early discharge is important. Again, who should go and see the patient?
2 hours postpartum, or?
Yes, postpartum. Our postpartum after normal delivery, because some of our patients, unfortunately, over there, they stay longer. Sometimes because of the sake of the baby, because of this, the longer they stay in the hospital, the more chances that they will get some infection. So the idea now in almost all UK hospitals, normal vaginal delivery with no complication, they should go home within 2 hours. I don't know whether this will be applicable there, but it's something to think about.
Thank you, Prof. Khalid. Regarding this last point, regarding minimizing or the duration to stay in the hospital, of course, the situation now in the UK, they are in a disaster phase. So they have implemented that right now. But according to plans here in several hospitals, one of them is the National Guard Hospital. I was in a phone call with Dr. Azza a few weeks ago that, you know, in the third phase or in the disaster phase, then this is something that we would be considering. So the usual 24 hours, 48 hours postpartum, no, it will have to be significantly reduced in order to increase the bed capacity for COVID-19. So this is part of the plan, but when if la qadar Allah, we have to go into the disaster mode.
Dr. Yasir.
Yes, Prof.
مين who's next أنا ولا اللي؟
بروف نبيل تفضل.
مسموع دحين اللي قطع شوية.
يس.
اسمه؟
بعد البروف بعدك يا
بروف.
الله يعطيك العافية. الله يعطيكم العافية. أول شيء طبعا أحب أشكر الدكتور ياسر على الميتينج هذا very excellent very informative ما شاء الله، وكلنا استفدنا بما فيه إحنا the so called expert استفدنا ما شاء الله من الريزيدنت ومن الأسئلة اللي طرحت. الشيء الثاني طبعا أحب أشكر الدكتور محمود الدكتورة سارة. It was an excellent presentation. I enjoyed it. Really, I'm proud that we have residents that can present with such a quality of presentations. النقطة الأخيرة هي بالنسبة للفروق اللي لقيتها. I'm very glad that you discovered that there is a difference between our guidelines and the different guidelines in different countries. This means that we did not do the usual way of copy and paste. We did our own exercise, we did our own work, we did put our own word and our own recommendation. And we hope that, inshallah, in the future, all the guidelines that comes from all the different societies in Saudi Arabia comes from their own work, not the copy and paste approach that used to be used in the past. I'm sure now we have reached to a level that we can produce our own based on our own facilities and our own society, which is totally different than the ones that we used to receive before. Thank you all. Thank you.
شكرا Prof. Nabil. Thank you very much.
دكتور
ايوه تفضل.
ياسر.
دكتور هيثم.
Yes. But I have two comments.
تفضل.
Yeah, number one دكتور انه بس
دكتور هيثم
في
الصوت بيقطع دكتور هيثم.
يقطع الصوت؟
ايوه.
طيب انه بس ما نفتكر دائما انه في وقت البانديميك هذه ما يكون عندنا فيكسيتيف ايرورز وانه ننسى الاذر differential diagnosis، لانه احيانا الواحد يكون preoccupied بالوضع اللي حواليه ويركز بس انه هذه كوفيد او هذه، ويكون في other diagnosis or other pathology that we are missing. هذا والعكس صحيح especially في السيفير cases والcritical cases. هذه one comment. السكند comment انه نحرص ونهتم انه نعمل قد ما نقدر obstetric drills وسيموليشن قد ما نقدر، لانه وقت ما تحصل الكيس we go in chaos sometimes because of the stress, because of الفير نفسه. and we might endanger ourselves without knowing. فهذه النقطتين بس ابغى اذكر نفسي والزملاء فيه.
شكرا دكتور هيثم، الله يعطيكم العافيه. طيب
معلش يا ياسر، بس في آخر كلمة، شكرا جزيلا على الهاف داي اللي المفروض بس يكون الريزيدنت حقونك تحول إلى هاف داي للمملكة كلها من الغربية لحد الشرقية، ما شاء الله تبارك الله.
لو كمان البحرين يعني ما شاء الله،
والبحرين ما شاء الله، واليو كي كمان ما شاء الله تبارك الله. ف I am so proud of this. الحمد لله. I am so proud of the SSMFM guidance. And I'm very impressed with your resident, mashallah, tabarakallah, and their presentation and their capability of producing such a high product of presentation. تعلمت اليوم إن شاء الله تبارك الله. It's enriching discussion. وبس حبيت أقول لكم شكرا.
الله يعطيك العافية. هذه كانت الدكتورة إيمان السلمي، دكتورة إيمان السلمي رئيسة الجمعية السعودية لطب الأموم والجنين. شكرا دكتورة إيمان، الله يعطيك العافية.
العفو.
So we'll just, a few questions, to answer. I noticed lots of the questions were already addressed when Dr. Sahar continued her presentation. So there's a question here with Dr. Saleh that Sahar, you mentioned fetal ocular toxicity as a contraindication to hydroxychloroquine. So are we going to use it or not?
Thanks for the question. I did not mention that it's a contraindication because all the guidelines, as I mentioned, it's a category C in pregnancy, so it can be used if the mother needs the medication. But there is a risk of, in some cases, that there is a risk of fetal ocular toxicity. This is in utero. So we'll screen the babies after delivery, but that does not mean that we stop using the medication.
So excellent answer, Sahar. So definitely the benefits outweigh any risks. So yes, we will be using the hydroxychloroquine.
Plus Dr. Yasser.
أيوة. تفضل.
Yeah, and also
دكتور هيثم شكل الارسال عندك ضعيف، اذا ممكن تروح منطقه. دكتور هيثم الارسال ضعيف، الصوت مقطع او صوت غير واضح.
experience with hydroxychloroquine لانه بيستخدم من احتمال. اوكي
في معانا كمان بس يعني before we continue the questions الدكتور حاتم الجفري. دكتور حاتم الجفري رئيس المجلس العلمي للنساء والولادة. فدكتور حاتم, do you have any comments دكتور حاتم؟ and we
الحقيقة أنا بدي يعني أولا أشكركم قبل لا أخرج لأن عندي اجتماع ثاني. Thank you very much دكتور ياسر. ومعانا الدكتور أبو ثينة. الدكتور أبو ثينة is leading a very big الحقيقة يعني effort in this nationwide، وإن شاء الله طبعاً كل منطقة الخليج معانا البرامج الأخرى حيكون في عندنا activities لكل الريزيدنت بحول الله. و I have to congratulate سحر ومحمود، وصراحة يعني very 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 well done. وشكراً دكتور ياسر. Thank you very much.
الصوت أفضل
لكن I enjoyed it actually.
الله يعطيك العافية. شكرا دكتور حاتم، الله يعطيكم العافية. ونشكرك ونشكر الدكتور أبو ثينة كمان والدكتورة في التحضير للقاء اليوم this activity. So now just going back to the questions, I'm just looking at the questions. I don't know if there is any questions left. So there was a question from Afnan. Sahar, do we consider the baby as a case of COVID-19 when the mother is COVID-19? And if we're going to isolate the baby from the mother, where are we going to isolate the baby?
According to the Saudi Society of Fetal Maternal Medicine guidelines, yes, we will consider the baby as a suspected case of COVID and will do the test on the baby until it's negative. And if we are gonna isolate the baby, it's gonna be isolated also from the effect of the mother for the mother to be cured also from the disease. So it's gonna be isolated for 14 days for both the safety of the baby from the mother itself and also for clarification and analyzing that the baby is off and not having the disease. The place where we're gonna isolate the baby, I'm not sure about it, but it's according to the Ministry of Health, the guidance for the baby.
Yes. So again, it depends on your neonatal unit, so in your hospital. So, most of the hospitals, they're going to request that the baby is, for example, taken care of in the same delivery room before taking it out. So again, depends on your hospital policy and of course the Ministry of Health policy with regards to babies born to COVID positive mothers. So there was another question regarding if a patient with suspected or confirmed COVID-19 and she's in second stage of labor, what about multiple PV examinations? Do they still need to do full PPE?
If we're gonna conduct the second stage of labor, and if the patient is pushing, is considered like arousal generating procedure, or there is a risk of delivery, as if we are dealing with multiparas, she might deliver anytime. Yeah, you should be prepared wearing a full PPE during the second stage delivery while you are conducting the delivery.
Okay. Any other comments by anybody? Anybody has any comments?
دكتور ياسر.
تفضلي دكتورة سميحة.
اسمح لي ارجع اعلق على موضوع الايزوليشن. For the mom isolation, it's going to be for 14 days or until her 2 tests become negative. For the baby will be taken into isolation until the first sample, the nasopharyngeal sample, and all the samples come negative, which might take up to 72 hours. Okay. After those 72 hours, the baby can go home and be looked after by a healthy provider. But the isolation in the hospital will be according to the guidance, but most likely it's going to be in the isolation in the NICU. If there is an isolation room in the NICU. If there is no isolation room in the NICU, then probably the hospital should consider, emptying one room. If they're dealing with multiple COVID patients, emptying one room to isolate those neonates. So I think that this is based on the hospital policy, but one way of doing it is to separate, have a separate room only for those babies of COVID-19 mom for the first 72 hours. And if the baby tested positive, then it would continue the isolation as per protocol. So until the 2 samples become negative.
Thank you, Dr. Samiha. Thank you very much. I don't see that there is any more questions. So I think with that, we can...
دكتور ياسر.
Yes, who is this?
السلام عليكم. معك أحلام الغامدي، الدكتورة أحلام من الشرقية.
من الخبر. أهلا وسهلا، كيف حالك؟
مستشفى. أول شيء أشكركم على البرزنتيشن والمحاضرة القيمة هذه، وأشكر الدكتورة إيمان للدعوة، دعتنا يعني بالفعل سمحت لكل الريزيدنتس الموجودين في الشرقية والبحرين إنه يشاركوكم. كانت محاضرة جدا مفيدة ورائعة. فمن هذا المنطلق يعني أتمنى إنه تكون عندنا الهاف داي يعني activity، إذا عرفنا في مواضيع كذا مشتركة تكون over the nation not only in a region، يكون جميل جدا. فإذا نقدر نتبادل المواضيع ونعرف متى أوقاتها for everybody إن شاء الله.
إن شاء الله بإذن الله. Dr. Hythem Alsum already left us, but I discussed this with him, and there is a plan that يعني في حيكون activities conducted maybe every month, nationwide activities, especially in topics that are needed in all areas. But I think this is going to continue. Maybe we just started it, alhamdulillah, لكن it will continue إن شاء الله. أظن هذا من المجلس العلمي. أظن دكتورة بثينة تضيف.
السلام عليكم ورحمة الله وبركاته.
السلام
عليكم السلام.
بثينة الله يعطيكم العافية.
جزاك الله خير دكتور ياسر وكل الكونسلتنت في ماتيرنال والمتدربين أبدعوا ما شاء الله. بإذن الله حيكون في بلان فور ناشونال إديوكيشن and good start بالدكتور ياسر جزاه الله خير. وإن شاء الله after we finish the schedule we'll send it through المجلس العلمي إن شاء الله.
تمام. يعطيكم ألف عافية. شكرا جزيلا. مع السلامة.
شكرا الله يعطيكم العافية جميعا. So to conclude, I would like to thank everybody for attending today. يعني it's been almost 2.5 hours. A very interactive session, lots of questions and answers. And I would like to again thank our presenters today, Dr. Mahmoud Khan, Dr. Sahar Hussein, for the excellent presentation. I would like to thank all the residents who took the time to be with us today and to attend this important talk. I would like to thank our MFM experts who were here and gave us their also feedback and opinions with regards to the different parts of the lecture. And I would like to thank everybody who participated with us today. Well, mashallah, this was a nationwide activity, not only nationwide, but وصلنا Bahrain and the UK also. So, and we hope that these type of activities continue. It's residency education is very important, and it shouldn't stop because of the crisis. We have other modalities of doing that. والله يعطيكم العافية جميعا وإلى اللقاء في يعني أنشطة أخرى مستقبلا. جزاكم الله خير. And have a great weekend.
Hello. Sorry to interrupt. This is Dr. Shireen. I have a question regarding the PPE wear. Since the patient, if she comes in early labor, if she's in early labor, she's going to go for vaginal delivery. Our deliveries in Bahrain usually conducted by midwives, and the doctor will be assisting the patient also. So if we go and assist the patient, do we wear full PPE? How long can we keep the PPE? Should we discard it again and wear it again once till we are cold, or because we keep assessing the patient every 2 hours? Although the delivery is conducted by a midwife, we keep see the patient 2 hours as our protocol from the delivery unit to see the CTG and to see how far as the patient is progressing.
Thank you. This is an excellent question. Dr. Sahar, do you have any answer?
As we mentioned, that we should explain with the patient the risk of home delivery, even midwifery delivery. So we should explain to the patient the risk of that. We mentioned should be conducted by a senior obstetrician, and the patient need to be on continuous CTG. Yeah, we can minimize VE. It would be done as per obstetric indications only. So from the point of having the patients to be seen by a midwifery, this is not going with the recommendations.
Regarding the person who asked the question, was that Dr. Sarah?
Which question?
The question, what's your name, Doctora?
Dr. Shireen.
Dr. Shireen. Yeah, did you ask about home delivery or you're asking about midwife delivery?
No, because our deliveries in Bahrain are usually conducted by a midwife.
Okay.
And
no, I got your point. So you're asking about frequent vaginal examinations during labor.
Frequent vaginal examinations and the use of the PPE.
Yes.
Do we have to wear the PPE, the same PPE? Should we keep wearing it, or should we wear another PPE for every 2 hours?
My own personal opinion, and also will take the opinions of my colleagues who are with us also still online, is that as long as you are with the patient in the room, you are wearing full PPE. If you're going to be leaving the room, then you're going to do the doffing as explained earlier. And then when you're going to come back again to assess the patient, then you're going to do the donning all over again. So you're going to wear a new PPE, new donning.
Okay, thank you very much.
Any other answers from my colleagues?
أعتقد دكتور ياسر the main issue with the PPE is actually the N95 mask. So if it's a confirmed case, there are every hospital have issued their own guidance with regard to the potential reuse of N95 mask and the number of times that you use it. So I think what you need to do is to consult your ID department and follow their guidance, because our guidance is a general guidance. But what you need to actually do is to contact the ID department and ask them about their own recommendation, because those recommendations are going to be changed based on the availability of the equipment. So, and the major shortage are in the surgical masks and in the N95 particularly. Many centers, they said that the N95 mask might be used, but each center have got their own limits for the number of times that they can be used.
Thank you, Dr.
It was very informative answer. Thank you.
Thank you all very much. Thank you and have a great weekend. Assalamu alaikum.
يعطيكم العافية جميعا. السلام عليكم.
وعليكم السلام.